Good morning, everybody, and welcome to this first POSI webinar. And we have with us Dr. Mark Camp from University of Toronto, and he is going to speak to us on a very interesting topic on mismontagia fracture dislocations and complex radial neck fractures. We welcome you, Dr. Mark, and over to you.
Oh, thank you very much for having me. And I'm greeting you from a very cold Toronto, where it's currently minus 14 degrees. So if I shiver, please excuse me. I'm Mark Camp. I'm a pediatric orthopedic surgeon at the University of Toronto and at Sick Kids. And it's a pleasure to join you today for this webinar. I've got only one thing to disclose, and that's I'm a faculty member at the Canadian Pediatric Orthopedic Trauma course, where my board and lodging is reimbursed. And, you know, for any pediatric orthopedic surgeon or orthopedic surgeon starting out their consultant practice, I would really recommend reading Kruger and Dunning's article where they explain their cognitive bias, the Kruger-Dunning effect. And that's where they demonstrate that with just a small increase in expertise, you can rapidly increase your confidence. But unfortunately for us orthopedic surgeons, with a slightly more amount of expertise and experience, your confidence can really take a beating, and you get to come to what I term the pit of despair. And I can think of no injury that we deal with in pediatric orthopedics or injuries that have a deeper pit, more difficult to get out of than those mismontagia fracture dislocations and complex radial neck fractures. And I like to give this talk together, discussing both these injuries, because the anatomy is so intimately connected. And we tend to categorize these fractures in two distinct types. But I think as we get more imaging, we'll start to divide these fractures up into many more entities than purely montagia fracture dislocations and complex radial neck fractures. So let's start with late presenting montagia fracture dislocations, and by that I mean those fractures where the ulna has already healed. And I think anyone who treats these injuries quickly becomes a very big proponent of educating those individuals in the medical workforce that deal with these injuries acutely. Because as the saying goes, an ounce of prevention is worth a pound of cure. You know, ideally, I don't want to ever see a mismontagia fracture dislocation because they're really difficult to treat, and they're far easier to treat if you get them acutely. So I never miss an opportunity to teach an emergency room physician, a family physician, general practitioner, or community orthopedic surgeon on how to evaluate pediatric radiographs to ensure that they're not going to miss a dislocation. And just briefly, I also never fail to miss an opportunity to teach my residents and fellows and community orthopedic surgeons about how to manage acute montagias as well as possible. And I think the best starting point for those individuals is Ring and Water's article from 1996, where they advanced the idea of an ulnar-based approach to montagia fracture dislocations. And just briefly, for those who aren't familiar, they recommend a close reduction and casting for incomplete fractures, for stable fracture patterns of the ulnar and intramedullary wire. And for this, I just use a stainless steel K-wire rather than an expensive elastic nail, because I'm not really using the properties of an elastic nail. And then for unstable fracture patterns, those fractures that can shorten, you want a plate osteosynthesis to maintain the ulnar length and therefore aid in reducing your radial capitellar joint. Now, in our institution, we don't have the resources to take every single montagia fracture dislocation to the operating room. So we tend to actually perform close reductions on the majority of them, cast them, and only if they fail do we then take them to the operating room. Indications for an open reduction would be an irreducible joint or an unstable reduction despite the ulnar fracture fixation. And the reason for that is because there's significant morbidity associated with opening the radiocapitellar joint, not only stiffness, but avascular necrosis of the radial head. Now, two additional points I'll just make on treatment of acute fractures, and adding on to what Ring and Waters said, was that before you go ahead and open up the radiocapitellar joint, because of that morbidity associated with it, you really need to critically assess your ulnar reduction. This fracture here, you can see, is actually an extension, and occasionally your intraoperative fluoro isn't good enough and you need full-length forearm x-rays in the operating room to better assess that. And again, make sure that you're assessing the coronal and sagittal plane, but this probably needs revision before contemplating going to the radiocapitellar joint. And then an arthrogram is often very useful, and you'll see in this lecture that I hand out arthrograms like it's candy. Almost no patient leaves my operating room without an arthrogram. It gives me so much information, and it really dictates much of my treatment. And so you can see here with this arthrogram, even with an attempted reduction, you don't quite get that radius aligned with the capitellum. And you can see this filling defect. I'm not sure if my mouse cursor shows up here, but you can see this filling defect that is this entrapped annular ligament within the joint. And so then you know what you have to do, and you need to go and fish it out. But despite your best efforts treating acute Monteja fracture dislocations and really educating the emergency physicians or orthopedic surgeons who deal with the acute injuries, missed Montejas are still going to find their way to your clinic, and depending on where you live and the size of the population you serve and the medical resources available, these type of cases present more commonly than not. And I present this case. This is an 8-year-old boy who presents to my clinic. It's not the most obvious Monteja fracture dislocation. Obviously, it's far more subtle than this. But the reason I chose to use it as a case example today is that oftentimes, although the radiographic appearance is far more subtle, the clinical or functional deficits can be more pronounced than a grossly dislocated radial neck. So if possible, it's really useful to try and get the story thus far. So I really try and get the family to go and find all the medical notes that involve the treatment of the fracture up until now. Try and get hold of any radiographs that they've had, so they can really get an understanding of what the original injury was, what structures were actually injured, and what has been tried thus far and was unsuccessful. So in this case here, again, this 8-year-old boy, you can see that he's got a anterolateral fracture dislocation with a comminuted proximal ulnar fracture. You can see that the ulnar is in varus, and he's undergone a very reasonable closed reduction. And I don't want to be too critical here, because obviously I've got the benefit of hindsight and also self-selection, in that only those that have failed come and see me in my clinic. Those that have been successfully treated, I never get to see. But you can see a couple of things. The first, on the left-hand side of the screen, you can see that the proximal ulnar is still in a significant amount of varus and the alignment hasn't been restored. So that's going to functionally shorten that ulnar and probably detension the interosseous membrane, making the radial head unstable. And then in viewing the sagittal radiograph, you can really appreciate, if you look really closely, that radial head is not perfectly lined up with the capitellum. But I can totally understand what the orthopedic surgeon is thinking at this point. He gets a cast change, and on this radiograph, you notice that the radial head is lined up much better with the capitellum. So potentially you had some hematoma that's now been displaced, and the biceps is relaxed a little bit, and the radius is now sitting better in the radial notch of the ulnar, restoring the Prudge anatomy and the radiocapitellar anatomy. But once the cast comes off at 6 weeks, again, you're a little bit nervous, because subtly this radius is just sitting a little bit anterior to the capitellum. And you can see that the orthopedic surgeon's nervous enough, because they've had flexion and extension x-rays to better assess whether there's actually a true subluxation And what was originally thought to be pronation deficit, just because the kid was casted in full supination for 6 weeks, ultimately does not really return. And there is now a much more obvious subluxation or dislocation of that radiocapitellar joint, at least when the arm is held in a neutral position. So I don't really think really well on my feet. I try and do all my thinking before the operating room and going in with a really good plan. But when I see this patient in clinic, the very first question I ask myself is, okay, if I can get this reduced and maintain a stable reduction after my surgical intervention, is the shape and size of the radial head going to allow normal range of motion? And as Kenny Rogers sang, you've got to know when to hold them and know when to fold them. And I think we're guilty as orthopedic surgeons, really focus when we deal with Montijo fracture dislocations, we're really focusing on the radiocapitellar joint and the sagittal plane. That's how we get our x-rays. We'll obviously look at the AP x-rays as well on the coronal plane, but that's what we're evaluating. And I think we really have to start thinking in the axial plane, because the radius not only has to sit back comfortably articulating with the capitellum, but it has to articulate well with the ulna. And you're probably shocked to see me showing pictures of 8 plates and growth modulation in a talk on Montijo fracture dislocations. But I really think this concept of cartilaginous growth is really important. The capitellum really functions like an 8 plate, maintaining the concavity of the radial neck. I hope you didn't get to see that email announcement. But anyway, the capitellum really acts as an 8 plate, maintaining the concavity of the radial head. And if you have a dislocation, then all of a sudden you've got abundant cartilaginous overgrowth in all directions, as the epiphysis has less pressure placed on it. And so all of a sudden you have cartilaginous cell division. And very soon you've got a radial head that is no longer concave and will no longer articulate well with either the capitellum or the proximal ulna. Now, in different hands, we'll all have different thresholds at which point we'll feel that we can no longer safely get this child through surgery to a point where they're actually going to have pain-free forearm and elbow range of motion. And so rather than giving you a time cutoff, which has previously been given at about 6 months or 12 months post-injury, where you might elect not to go ahead with reconstruction, I would recommend getting an MRI, or if not, a CT arthrogram, to really assess the cartilaginous size and shape of that radial head to determine whether or not you can safely get this joint to move after your surgery. Obviously, first principle, do no harm. You'd hate to go through the big rigmarole of putting this kid through major surgery and ultimately cause him more harm than good. If you do decide to go ahead with surgery and you think you can get this kid a good result, really you want to manage patient and parent expectations from the outset. Even in surgeons who live in the elbow can only get an 80% success rate. And so it's really important to let the family know that it might be that you cannot get a good result. It's far easier dealing with parents or patients when they know upfront that they can't expect a perfect result every single time. This is a fantastic article, and this article from 2016, along with this article from Teddy Schlongo and Fernandez in 2011, really frame my thoughts on these late presenting Montijo fracture dislocations. Even if you don't speak German, Google Translate really does a fantastic job of giving you Teddy Schlongo's thoughts on this topic. And I don't think much is lost in the translation in terms of how forthright he is in terms of certain principles, particularly how important that ulnar osteotomy is to retensioning the intraosseous membrane, as well as how infrequently needed a annular ligament reconstruction is required. So the next question I asked myself is, what are the blocks to reduction? And for many years, and possibly because I was worried about acute montiges, I assumed that ulnar length was really important in terms of a block to reduction. But in actual fact, you've got enough shuck in your interosseous membrane at the drudge and in the prudge that very rarely is ulnar length a reason that you can't get a reduction. Now, don't get me wrong, ulnar length is exceptionally important in terms of maintaining our reduction, and I'll get to the reasons for that in due course. But it's very rarely, unless you've had a very shortened ulnar that was mistreated or a long-standing injury, that the ulnar length is going to be a significant block to reduction. Far more important would be an assessment, ideally with an MRI if you've got the resources, to assess the prudge, where your annular ligament could be entrapped or some scar tissue could be blocking great reduction, or in the radiocapitellar joint itself. And it's nice to know what your blocks are to your reduction before you go to the operating room, so you can start planning incisions and approaches appropriately. So here you can see that annular ligament acting like a doorstop between the radiocapitellum and between the radial head and the capitellum. And if you don't have access to an MRI, then an intraoperative arthrogram at the start of your case can really assist. And so here you go again with that arthrogram showing you that entrapped annular ligament. And I've just changed the contrast here, which probably shows it better. You can really see that annular ligament entrapped between the radius and the capitellum. So back to this case of the 8-year-old, and here with us, you can see that annular ligament entrapped in the joint, blocking pronation. In extension, you can see that he's only subluxed, and you can tell that he's got good concavity of his radial head. You want to assess your axials, you want to assess your prudge, and again, you can see that the radial head is not too large. It's going to work nicely in the prudge. The prudge doesn't have much schmutz or scar tissue that needs to be removed. And then the axial plane here really shows how that annular ligament has flipped into the joint almost like a bucket handle meniscal tear and needs to be flipped out and repaired. So once I've looked at that, next question I'm going to do is, or ask is, how am I going to maintain the reduction? And so a little bit of an anatomy lesson here. Your radiocapitellar joint is stabilized by 3 things, and it shocked me when I learned this. I always assumed that the annular ligament was vital, and that's why in historic texts and the major orthopedic textbooks, so much was written about the Bell's-Torres reconstruction and reconstruction with different types of structures. But in actual fact, your intraosseous membrane is by far and away the most important structure that stabilizes the radial capitellar joint or your radial head. And of that, the proximal band is most important. Your annular ligament only gives you another 20%. And you get about 5% or so from the congruency of your radial head. So understanding this anatomy can really allow you to target interventions that are going to give you the most success with the least amount of morbidity. So your primary goal when dealing with these is to retension the interosseous membrane. And so here's the, on the top, you've got the injured side, and the bottom, I'd like to get a contralateral radiograph. You can get the uninjured side, and you can see that there's really no sagittal plane deformity in this particular case. But when you take a look at the coronal or coronal alignment, and you can see that there's far more varus on the left than on the right. So correcting that will help to restore some of the tension on the interosseous membrane. And I think knowing that your interosseous membrane gives you the best bang for your buck, your ulnar osteotomy is the method in which you're going to retension your interosseous membrane. And so you're much better off with an ulnar osteotomy with distraction and flexion to retension or even overtension that interosseous membrane, so that you don't have to go to the radiocapitellar joint, perform an arthrotomy, and if you don't have to. Now, obviously, if you have an entrapped annular ligament, or you've got scar tissue within the prudge that needs to be removed to get a stable and concentric reduction, then obviously you're going to go ahead and open up the radiocapitellar joint. But you should only do that once you're absolutely certain that you've maximized the tension of your interosseous membrane. Teddy Strongo is a big proponent of this, and I am too, where your osteotomy needs to be as simple as possible, and it should really be performed best, I think, at the proximal metadiaphyseal junction. And the reason for this is it retensions your interosseous membrane best, but it also has a fantastic healing ability. You really need bone grafting, and your risk of non-union is diminished. Now, occasionally you don't have the option to use a transverse osteotomy, perhaps because someone else has already gone ahead and performed surgery. And in that case, you are left with a oblique, either fraction non-union or oblique osteotomy, and an articulated tensioning device is really helpful to aid in distraction, because in an oblique osteotomy, you can't use your laminar spreaders, which I like to use for my transverse osteotomies, because you start getting a malunion or malalignment in the coronal plane or in the sagittal plane that you weren't expecting. Please don't think that I advocate for a plate on the lateral side of the ulnar. I typically like to have my plate posteriorly because I can use it as a tension band, and I actually flex my plate so that I can get maximum distraction and flexion at the ulnar to maximize my tension on the interosseous membrane. In this case here, I just went, I used the same approach and fixation methods that were provided to me by the previous surgeon, but it's not something I'd recommend. And in actual fact, I would discourage anyone for doing anything complex other than a simple transverse osteotomy in the proximal metadiaphyseal junction, because it just adds complexity to an already complex operation. With an oblique osteotomy, you're much more likely to get malalignment in the plane that you're not focusing on. So in this case here, the surgeon might have gotten great flexion, but he ultimately paid for it with shortening in the coronal plane for a net result of 0 distraction at the fracture site. And you know, in young kids, yes, I know the posterior plate is going to be prominent and you're going to have to take it out, but you're likely going to have to take this plate out regardless. And so I don't see much benefit to this osteotomy whatsoever. I always obtain post-operative radiographs prior to discharge. You know, when a patient's asleep, the biceps is quite relaxed. And so once they wake up, that bicep starts to fire again, and you really get to a good assessment of whether or not you've got a stable, congruent reduction of your radiocapitellar joint. It's far easier to deal with a complication when the patient hasn't even left hospital, and you lose less trust from the parents than if you've discharged them home without that x-ray and they come back to see you in clinic 2 weeks later or a week later, and now things are falling apart. It's very quick to lose the patient's and parents' trust in that situation. Annular ligament reconstruction is usually unnecessary. I think there's a growing body of literature to suggest that you know, you can really reposition the annular ligament in many cases rather than having to reconstruct. Oftentimes, the annular ligament tears in a horizontal or transverse orientation and flips into the joint like a bucket handle tear. And if you approach your arthrotomy from proximal at the capitellum and you look very carefully, you can ensure that you don't damage the annular ligament and try and flip it back over the radius such that it's performing its duties again. A transarticular radiocapitellar wire is almost never required. The exception to this is occasionally you might want to use it, as described by Don Bay, to judge the amount of distraction required at your ulnar osteotomy. So you can perform your ulnar osteotomy, you reduce your radial head, you put a transarticular radiocapitellar wire temporarily, intraoperatively, so that you can judge the amount of distraction required at the ulnar, and then you can remove it prior to closure and prior to the end of the operation. I wouldn't recommend leaving it in after to stabilize the joint while the patient's in a cast, because if it breaks, it makes for a very challenging revision case. So let's just, I'd like to end my thoughts on missed Montijo fractures there. I haven't spoken about distraction osteosynthesis or osteotomies that involve external fixation. That's dislocations. I also would like to admit that there's probably many ways to skin this cat, but I'm hopeful that some of the points that I've mentioned today will be food for thought in your own practices, and hopefully together as a community we can improve our experience and knowledge of these difficult to treat injuries. So moving on to complex radial neck fractures, another bane of my existence. So here's an 8-year-old girl with a ulnar humeral dislocation, radial neck fracture, ulnar shaft fracture, and a distal radius buccal fracture. She was treated by a surgeon at a long arm cast after closed reduction. And at 3 weeks, because the surgeon was worried about stiffness, transitioned her to a short arm cast and then allowed range of motion. And unfortunately, she then shows up to my clinic at 6 months with decreased flexion and no pronation and supination. And here's her CT scan, and she's now in a big deal of trouble. Not only does she have disruption of the radiocapitellar joint, so you can see that this radial head is now going to start getting bigger and bigger. Without that pressure of the capitellum on it, it'll become less convex, so it'll be less congruent. But she's also got a malunion of the proximal radius with a mismatch of her prudge. The angle of rotation, or the axis of rotation of her shaft doesn't match the axis of rotation of her radial head, and so she's got this camming effect, which basically decreases her range of motion. So the best defense is a strong offense, as shown by the greatest batsman of all time, A.B. de Villiers. No, I'm joking. I don't want to make any enemies here. But it's really important. This is not rocket science. We can all treat radial neck fractures. I think what's really important is not to underestimate the instability of the fracture, and thinking that casting alone or cast immobilization alone is going to be sufficient in these unstable complex radial neck fractures. So again, I really educate my residents and fellows to think about these fractures and ask yourself 3 questions when dealing with radial neck fractures. And the first is there significant translation at the proximal radial fracture site? Because that will tell you whether or not you've got the inherent stability of an intact periosteum that might help with maintaining your reduction. I think historically, treatment algorithms for radial neck fractures have really highlighted and emphasized angulation as a rationale to go ahead with reduction and fixation. But I think far more importantly is translation. And I think that should be emphasized when looking at radial neck fractures, because that translation is going to tell you, one, whether or not you've got inherent stability at the fracture, and two, whether or not you're going to have a mismatch of your axis of rotation of your shaft and your head, and therefore whether or not you're going to get camming and ultimately decreased forearm pronation and supination. Next question I ask is the ulna stable? And the ulna can be unstable for a couple of reasons. The one is that you've got a fracture that's in an oblique orientation that might be prone to shortening, or whether or not the ulna is unstable because you've had a dislocation of the ulnar humeral joint, and so that you could have a redislocation. And in both those examples, you can get your radial head squeezed between your capitellum and your radial shaft, like you squeeze a watermelon seed between your fingers, and it can shoot out anteriorly. And next, I ask, are your capsular constraints lost? Your capsular constraints, including your annular ligament, can act as secondary stabilizers of your radial head. And so if they are not intact, you can't just rely on cast immobilization alone to maintain your reduction. You're going to have to augment your cast with some other fixation methods. So if my answer, if the answer to those questions is, to any of those questions is yes, I really strongly recommend that you add fixation methods of your choice in addition to cast immobilization to minimize the risk of a bad result. Now, I'm not advocating aggressive open reductions on all these cases. In fact, I think you should be both exhausted and desperate before opening the radiocapitellar joint. What I'm recommending is a stepwise approach, starting with closed reduction, then going with percutaneous reduction methods, potentially a metazoa technique, and then only once you're exhausted and you've tried everything else, proceeding with an open reduction. So here's a case, and you can see that in this 11-year-old who's fallen off a bicycle, you can see that you have significant translation of that fracture. You probably have lost a significant amount of your inherent stability of the periosteum in this case. You can note that the radial shaft doesn't line up with the capitellum, and so you've lost some of your secondary stabilizers. And so in this case, I've gone ahead and tried to use all my percutaneous methods, including levering and pushing on that radial epiphyseal fragment to get a reasonable reduction. At this point, if you aren't perfectly satisfied with your reduction, you've got a couple of options. Your next option would be to potentially use an elevator placed on the ulnar side of the radius from posterior to translate that radial shaft by pushing on the biceps tuberosity, and you're going to translate it laterally while reducing the epiphyseal fragment medially. Or you can consider a metazoa technique to get a perfect reduction. I'm not good enough to use a metazoa technique when you've got a completely off-ended radial neck, but once I've got it in the ballpark, then my metazoa technique is very worthwhile. And so here's your final reduction. And I would really advocate that complex radial neck fractures deserve more than casts alone. You've placed this patient under all the risks already. You've tried to injure her or tried to avoid injury to the posterior interosseous nerve with your percutaneous assisted reductions. And so I don't think there's much further risk by using fixation to maintain this reduction and ensuring that you minimize the possibility of a poor result. I like to use percutaneous wires to obtain a reduction, but I'm very careful relying on the same wires to maintain a reduction. And so looking at this case here, You can see that I've stabilized the ulna because I don't want it to shorten and have that radial epiphyseal fragments get squeezed out between the shaft and the capitellum. And you can see that I've, or my fellow in this case, is really levering on that epiphyseal fragment to get a good reduction. But with that leverage, you can see how much tension is placed on that wire, and that tension can be transferred to the posterior interosseous nerve. You might not see the nerve palsy post-operatively day 1, but when they come back to your clinic at day 7, that's when they've got a wrist drop. And so if you are going to use percutaneous wires, I would recommend placing another wire at this point to cross the fracture site without any tension placed around the area of the posterior interosseous nerve. I actually prefer to use a metazo technique at this point, and I think a sharp bent K-wire, bent 10 degrees or so, about a centimeter from the tip, is your implant of choice. 1, because it's cheap, and 2, because the titanium elastic nail is blunt, and it basically just pushes that capitellum away from you rather than engaging into the epiphyseal fragment. So here you have a fracture of the proximal radial epiphysis with the ulnar shaft fracture. An arthrogram is exceptionally useful. It gives you that confidence to bang that wire across into that epiphyseal fragment and capture enough of it to get a stable or maintain a stable reduction. And so you can see here, without that arthrogram, I'd be far too cautious and would probably leave it short and not capture enough of that epiphysis to get a stable reduction. And you really want to get enough of a reduction. And the benefit of the metazo technique here, and in particular this use of the K-wire, is that you can probably get this moving earlier than if you were to use either percutaneous wire or a cast, so that you can decrease that potential of a devastating synostosis. Again, you need to manage patient and parent expectations from the outset. You can't make a silk purse out of a sow's ear. And it's a lot easier when you end up with this avas necrosis and complication if the parents understood the gravity of the situation that they faced at this point. Having a lengthy consent discussion will pay dividends when you end up with this likely result. It's very difficult to get a good result with such severe displacement, and AVN would be exceptionally likely. And then finally, I haven't found a fracture that keeps you more humble than these. You really don't want to celebrate too early. Here's a 12-year-old boy, fell off a skateboard, and you can see he's got a couple of reasons why I feel that this is what I term a complex radial neck fracture or an unstable radial neck fracture. 1, he's got significant translation, but 2, he's got a disruption of the radiocapitellar joint. So immediately I'm assuming that annular ligament is no longer doing its job, and I can't rely on it as a secondary stabilizer. So not to be caught with my pants down, I've done everything, and I've done a metazo technique here. And recalling this case, it actually went exceptionally easy. We were able to get a good close reduction and then maintain it with this wire, and got him moving pretty early. This is him at 1 month, and pretty satisfied with those results. Yeah, the radial neck is a little bit anterior. If I'm really critical, you've got a little bit of a translation there of about 2 millimeters or so, but overall very happy at 1 month. But then he comes back to see me at 3 months, and you can start noticing quite exuberant callus formation, which is what I'm terming auto overstuffing of his prudge. We see this in adults with radial head replacements that are too big. And you can see that this exuberant callus is now allowing anterior subluxation because the annular ligament is not intact. You know, at this point, I remember speaking to experts far and wide in my own institution, across North America and overseas, And the consensus that I got was, don't worry, that periosteum is going to settle down, and it will settle back into its prudge. But unfortunately, that's not what happened. And the callus just became more exuberant, and now you've got obvious subluxation at the radiocapitellar joint. And this patient is in a bad state with a very difficult problem. He doesn't have a synostosis, or he might have a fibrous one, but he has got a exuberant amount of callus right at the prudge. So he's not articulating at the prudge very well. He's camming because his arc of rotation is too big for the architecture of the radial notch in the ulna. And he therefore has limited pronation and supination. And I don't have an answer for this. And part of the reason why I always accept invitations to talk on this topic is because I learn so much from members of the audience who many times have much more experience than I have in dealing with these fractures, but also to start bringing out everyone's bad cases out of the woodwork so that we can start talking about best ways to actually treat this injury. I've yet to have a solid answer from any expert that deals with these injuries on how to either prevent this from occurring or how to treat this phenomenon when it occurs. But I can tell you that in my own practice, I have 3 or 4 patients that this has happened to. And at sick kids amongst my colleagues, I see this not infrequently. So I'd love your feedback and any answers that you might have for me in terms of how to manage, either how to avoid this from happening or how to manage it when it does occur. It's been an absolute privilege to give this webinar today as a small payback for all the wonderful teaching I've had from the Indian diaspora over the years. Obviously, Uni Narayanan has been a fantastic partner since I've joined Sick Kids. Abe Kot was a wonderful teacher when I was a fellow in Melbourne. Kishore Malpuri has been a long-distance mentor since I was an elective medical student in BC Children's back at the beginning of the millennium. And Abe Kamble was my senior fellow in Melbourne and was a great peer mentor during my fellowship. And I appreciate your time today. And hopefully you've taken some pointers back to your own practices that you might be able to use to try and minimize ending up with a poor result in these difficult to treat fractures. And I'd appreciate any questions, feedback, or advice on places where I might have it wrong, where my understanding of this might not be correct, or whether you've had good results with other strategies. Thank you very much.
Thank you very much, Dr. Mark. It was really an excellent and exhaustive lecture, mostly based on your own personal experiences and cases. So it was very, very interesting. Thank you very much for sharing all that with us.
Oh, you're very welcome. Thank you very much.